So good afternoon, everyone. Thank you for joining us from wherever you're joining us in the world. My name is Elizabeth Chalo. I'm the Project Associate at the Coalition for Women Health in Africa. So today I would like to welcome everyone to this exciting discussion around the impact of public-private partnership in advancing women cancer care in the Sub-Saharan Africa. I know you may ask where this discussion came all about. So let's start with just a reality check on the situation of cancer around the world. And I must say that cancer is a major health challenge, especially in the Sub-Saharan Africa. And according to WHO, you've reported that that 90% of the cervical cancer cases occur in low-income countries, and there is 4 to 5 times more likely of a patient suffering from cervical cancer to actually develop cervical cancer. So this is a wake-up call for each and every one of us. But now, here is the good news, and this forms the discussion of today's topic. Partnerships are making measurable impacts. For example, the partnership with Pink Ribbon and Red Ribbon has already vaccinated more than 147 girls across Zambia, Ethiopia, Botswana. And this is a challenge for each and every one of us in the health sector. So today we are honored to have 5 panelists, 5 incredible panelists. That is Nyawira Njeru, who is the Regional Director at Africa, or Logic. And we have also Adila Fakir, who is the Public Affairs and Market Access at PD. And Kuliliwe Mabaso, also in the discussion, joining us, is the Director of Government Affairs Africa at Harvard. And finally, we are joined by Dr. Keegan Batilol from the Ministry of Health, who is the Director of Health Standards and Quality Assurance Regulations at the Ministry of Health. Just to set up the whole discussion, so let's think about this team as the dream experts. They are ready to tackle the big questions and have very innovative solutions that will inspire us to call to action. They will also be able to guide us on how to explore partnership in transforming the healthcare of women in the Sub-Saharan Africa. So this session isn't just about listening, it's about learning, connecting, and living ideas that will make a difference in the health sector. Without further much ado, I'll just set a few ground rules for the session. So the session will be recorded. So it require you, or rather request you for your consent as we continue with the session. We would like to request you if you can mute your microphones through the session so that you may be able to avoid any possible distractions. And finally, feel free to share your questions, your engagement on the chat box, and we'll be able to respond to them during the Q&A session. So without much ado, let me I would like to pass mic to the fantastic moderator, Nyawira Njeru, to take up the session. Thank you.
Great, and thank you very much, Elizabeth, for laying out the groundwork and why we are actually having this webinar today. So truly appreciate the work that's been done by HB and the Coalition of Women's Health in Africa. And that's the reason why we are all gathered here today to deliberate on what more needs to be done if we are to move the needle and advance towards achieving the cervical cancer elimination goals by 2030. But also looking at how we achieve the goals laid out under the Global Breast Cancer Initiative. So to all of you joining us, good morning, good afternoon, wherever you may be, and thank you very much once again for joining us in this webinar session. I want to begin and say that this session comes at a very apt time when we have just marked 4 years of the 90-70-90 cervical cancer elimination goals and just concluded the Breast Cancer Awareness Month in October. Elizabeth has already shared with us some of the statistics, but we also do know that breast cancer is the most common cancer in the WHO Afro region. And this is from the data from the Global Pan 2022, with an incidence rate of about 16.2%, and followed very closely by cervical cancer with an incidence rate of 13.1%. But when we think about mortality once more, cervical cancer comes in as number one from a mortality point of view, and closely again followed by breast cancer. And it is because of this heavy burden of these two cancers that affect women that we do find that this webinar with these panelists that we have here today is really going to help us begin to unpack some of the gaps that we may be seeing today, barriers that may be existing that are blocking us from getting to attaining the goals ahead, but also looking at what has been done and what more investments need to be made to ensure that we can actually eliminate cervical cancer, but also move the needle insofar as attaining the Global Breast Cancer Initiative targets is concerned. These cancers, has been said, actually do account for a third of all cancer cases. And it is estimated that if we do nothing about cancer today, we will see a 46% increase in cancer by 2030. So I want to ask all of you to join us to have a really good discussion here where we can come up with some ingenious ideas that help us really turn the tide and bring down the statistics and be the generation that really does move the needle insofar as cervical and breast cancer is concerned. Elizabeth has introduced our distinguished panel, which cuts across private sector, that is industry, but also looking at the private public sector, and the Ministry of Health Kenya is represented here, as well as the Ghana Health Services being represented here. We are looking forward to a really deep discussion, looking at what is working, how public-private partnerships have enabled the process of us moving towards elimination goals, but also asking what more needs to be done as we advance and get closer to 2030. Now, just to frame the questions for our discussions, I want us to reflect on a couple of things. When we think about cancer management, unlike most of diseases, whether it is breast or cervical cancer, it is actually very complex because of the multiple points in the patient care journey that we know. On one end of the spectrum, we know there is a patient who is an individual, there is a community, there is a population. And on the other end is a healthcare system. So when we think about barriers and the things that we need to be doing to improve the situation and get closer to elimination, we really have to think not only from the individual side, but what work needs to be done from a health system, health infrastructure point of view to enable more women come in for screening, get treated, and we can therefore move closer towards the elimination goals. In the context of Africa, when we think about screening for both breast cancer and cervical cancer, several studies tell us that we're about 14% in terms of accessing breast cancer screening. I did read something else on the UK, which says that in the UK, at least one woman is diagnosed with breast cancer every minute. And whereas that statistic itself is staggering, it actually does tell us that in countries where there is effective screening programs as well as diagnosis, more women are actually being diagnosed earlier and therefore able to access care and treatment much sooner. So reflecting on this gap that we have in the context of Africa, when we think about access to screening, both for cervical cancer as well as breast cancer. And Hulu, I want you to weigh in onto this when we think about what is it and what barriers exist, right, that are preventing us from getting more women coming in for screening for both breast and cervical cancer. Thinking at it, in the full continuum from the individual, the community side, and also the overall healthcare system. And what do you think could be done to improve that situation? And I want to pose this over to you, Hulu, based on your experience within Abbott and also leading government affairs.
Thank you. Thank you so much, Nyarera, and welcome to everyone who's listening. I think it's a great discussion, and congratulations to AHB and COA for keeping this discussion alive and ensuring that we keep on talking about this so that we can increase that 14% number and make it higher. I'll take probably a step back and go to a time in Sub-Saharan Africa, right, when we had AIDS as this disease that was killing so many of our brothers, sisters, mothers, and leaving houses being run by kids. I think there was such a myth, right, in this disease. And at the time, there were, few companies were also able to bring the right diagnostics. But once education was actually given to community and at a community level, and we had all, so many companies and the health sector and government and funders really wanting to tackle this. That's when we really started understanding that, the sooner you check this, that, that we had other companies that were also providing medication, right? So then we started seeing numbers decline, and now you don't, I don't know what, some of you might have been around those days where, it was so evident, it was everywhere around. And I think cervical cancer, it's something similar to that. And maybe that's, I say this in terms of maybe we should take lessons from some of the things or some of the diseases that as a public health community, both in private, public, and the community and government, we were able to successfully work on, to say what are the key learnings that we got from them and how can we apply them to cervical cancer. I think one of it for me would be just the trying to understand the ethical myths and considerations around it. Also understanding like who are the trusted voices, right, for women, who are they mostly likely to listen to when it comes to just healthcare in general. And also probably, as much as we are saying that we are testing for cervical cancer, maybe we also need to start changing the narrative that I'm not testing for, whether I have cervical cancer or not, but I'm just, I am doing it's a prevention, right? It's a preventative effort that I do, and I'm taking care of myself when I actually go to the hospital and do the several tests that are there that actually allow me, if I have it, to actually know about it, or to actually have milestones and know that, how many times do I need to test for this? And the earlier I test for it, then there is so much cure for it. And not to make it sound like a, death penalty type of. So, that saying that goes like, I don't want to wake up like sleeping dogs. I'm not going to go and test, because what if I have it? Then mentally already, I am going to be so challenged. And I don't have, whether it's medical aid, what you don't have. So I think there's some narrative around it that we have to create, that we are doing this to ensure that you stay healthier for longer as a woman. It's not like we want to test because we think that you have it. One of the things also, I think, which I take as a learning, right, from what, just doing a correlation with HIV, is more on the traditional type of healings, these African, whether it's African healers or African myths or African medicine people, in terms of how much are we bringing them into the discussion as well, so that we can start educating them, so that if they are the trusted voice, they can then start also being advocates as women come to them to tell them that, why this is important and why they need to actually go for screening, and also take them through the actual testing in terms of how it's done, what is it that we are looking for, and how it will also be treated. And probably the last part, I think that I will also touch on is just understanding it's mainly it's education, right? So it's again on the sexual, as part of sexual education. It should actually be done earlier as well in schools. When we think about the reproductive health education, it's something we need to go back to work with ministries of health. I think they need to be part of this discussion in terms of how are we including, right, in the puberty healthcare education and reproductive health education in terms of preventative measures that you know, as a woman, you would need to take care of yourself at the different stages of life. And we know that, you know, once the kids are actually educated and they know about this, they will somehow be our advocates as well when it comes to moms who don't understand what PAPs, you know, what does it mean when you say it's, you know, you need to do a pap smear? What does it mean? What is it that they are looking for? Why do I need to go, you know, why do I need to go to the clinic when I'm doing all those things? So I think there's a whole lot of the ecosystem around us in terms of awareness and education and demystifying the myths. And just lastly, just learning from what we have done well in some of the diseases and bringing those lessons here and also, you know, putting them through. So maybe that's, you know, that's the first part that I can somehow touch on. Thank you, Yara.
And thank you very much, Fulu, for really looking at it from the continuum, right? From the individual and moving to the role that the community does play. And also the ingenious ideas of the role that education definitely does play, and how children become also part of the critical pathway, right? To be able to disseminate that information in a much more clear way to enable more women come in for screening, for example. Really demystifying the myths is what we are trying to say here. Which then actually got me thinking, and this one I want to weigh in with Dr. Keegan, right? WHO has actually published what they call the Patient Navigation for Early Detection, Diagnosis, and Treatment of Breast Cancer Technical Brief, right? Really thinking about the role that patient navigators can begin to play to address some of those challenges that Hulu was speaking about here, whether they're going to be working in the communities or working within the healthcare system to try and help us move forward. Dr. Keegan, in your experience, having worked within the Ministry of Health and also as an obstetrician gynecologist as well, how do you see us integrating this aspect of the patient navigators to enable us be able to break down some of these barriers and get many more women coming on board? Is it that we, you know, work through community health workers or community health promoters, whatever we are calling them in different countries? But I really want to hear your perspectives on how we can bring this to life to cover some of those gaps that Hulu has discussed here. Dr. Keegan.
Thank you very much, Nyawira. I'll just start with just a small history of how we have improved in terms of access, treatment, prevention of cervical cancer. Initially, the only test that we were doing was basically pap smear. But I think over time, we've done quite a bit as a country. We're now able, first of all, to do prevention through the HPV vaccination, assessed through the ministry and Gavi, where we're able to reach out to the different facilities. We did the pilot in 2014 in Kitui, and we have rolled it out throughout the country. So this has increased access to really prevention per se of cervical cancer. Number two is we came into screening. Screening, we have our guidelines, and we are very clear about the guidelines. There are several methods of screening. But what I just want to emphasize is the use of VIA-VILI and the colposcopy. Sorry, and VIA-VILI and cryotherapy. This we actually rolled out to the level 2s and level 3s, whereby they're able to access that. Then we moved on to the level 4 and 5 and tried to ensure that we have capacity for them to do colposcopy plus or minus LIS or LIP. Thirdly is capacity building in terms of cancer treatment. I think in the last 3 years, we have rolled out 4 cancer centers in regions. We've done, I think, 4 regions now, We still have planned for another 4 regions to increase the cancer treatment facilities offering radiotherapy, plus of course our Center of Excellence at KUTRH. So as we continue making guidelines, we know that this is the way to go forward in terms of prevention, early diagnosis, and treatment. But as you put it out, as a country, we are going towards universal health access, universal health coverage. And what we are using mainly is the health promoters. Currently, we have 100,000 health promoters within the country. Their work is actually to help. We're not telling them to treat actually themselves, no, it's to help us get early screening so that we can be able to get the disease as early as possible. More so is medication. We tell them how they need for a pap smear, the need for a screening method, whichever they are able to access, and appropriate referral. So this is a way we can actually use the WHO model into their curriculum. And part of the curriculum that they are being taught as the health promoters is actually on, apart from the NCDs, is on cancer prevention and treatment and screening. So I think as a country, we'll work with partners to be able to reach at this level of the community. With those few remarks, I think for us, it's just to say that we need to work more with all the partners to be able to reach everybody within the country. Thank you.
Great. Thank you very
Back
much,
to you.
Dr. Kigo. Thank you very much for weighing and really sharing the progress that Kenya has made and really how we can integrate, right, the access pathway to cancer diagnostics through using universal health coverage, and in Kenya in particular, using the community health promoters as well. And absolutely, I do see the linkage and how we can get more women coming in for care and probably utilizing the CPPs also to basically bust the myth that Kulu was actually talking about. Dr. Mary Efwe, again, just a bit on this, and I want to hear a bit from what you have experienced in Ghana, where, again, when we think in the context of community health workers or community health promoters, now turned patient navigators, and how they do or could help us be able to close those gaps that we are talking about, getting more women into care and leading them through the full continuum of care to survivorship. If you can share a little bit with us what's happening in Ghana.
Thank you very much. For us, quite a bit of work has gone on in terms of women. And there's been, from both the government side and then from the side of the private sector as well. I must say that private sector players have actually played a critical role in ensuring that women's health is promoted. Now, within the government sector, there's an array of interventions and strategies that have gone on. Thankfully, policy have been touched. I must say childhood cancers, which are also leveraging the positives of or the strides that breast and cervical cancers have made. But from our part, one of the key things that we are promoting is the capacity building for health workers in the primary healthcare setting. This is crucial for us because a larger chunk of the population are in the primary healthcare. And we see that with all the myriad of challenges in the health system, be it low awareness, late reporting, 75% of our cancers are reported very late. And as well as the limited, you name them, with all the delays in setup. The primary healthcare provider plays is crucial because they are indeed the gatekeepers, and having direct contact in the community gives you a certain advantage. They are the ones that can help to increase the awareness, working together with the community, together with volunteers, patients or survivors who have come back into the community, amongst others. Community health nurses in particular take a myriad of activities in the community. They undertake home visits, they undertake immunization, which are all opportunities that they are having contact with them. And as such, their capacity is built to the level such that any woman at all can simply walk in the health center and request for cervical cancer screening using VIA, pap smear, VILI, amongst others. It would be a key step in ensuring that in our attempt to work towards UHC, at least for cervical cancers, majority of our women have been screened. We recently launched our STEP survey that showed that it's just about 3.6% of women in Ghana that have ever screened for cancers. And this is huge for us. It's such a huge, but using the primary healthcare is as key in entering into the community and ensuring that the first 90 is captured is something that we believe we should be able to leverage on. Beyond that, in the private sector space as well, private sector players have largely helped in terms of treatment, acquisition of medications, and logistics as well. And a lot of private sector players from banks to NGOs, CSOs have come on board, and we just talked about patient navigators, and I was all smiles. Patient navigation has been used for breast cancers in Ghana, and this initiative was led by the private sector as well. And it has such huge positive findings. So the private sector has been crucial in our attempts to improve on women's health. And we believe that there are multiple lessons that can be learned in what has already gone on the ground, such that as we seek to expand the services and improve on care, there's no need to reinvent the wheel, and we can always leverage on the positive findings from various projects and activities that have gone on right in country. The work to get HPV vaccination institutionalized in Ghana has been such a huge collaboration between the private sector and government, such that we are finally going to be able to immunize our children beyond the initial pilot that was done. So quite a bit of work is ongoing, and there are multiple lessons that I believe we can learn from. Thank you.
Thank you very much, Dr. Mary, for sharing that with us and really weighing in on the role that community health workers definitely do play. And I like the linkage, because from your experience that they are actually in the communities, they really become, to use your word, the gatekeepers that can help us bring many more women into care and actually be able to support them even as they go through cancer care, knowing that it's not, one stop, that you get screened, you get tested, diagnosis, everything done all at once. But because it takes much longer, then we do see the great role that community health workers do play. You raised a very important point, which is on public-private partnerships and how we can leverage what is already working. And I think Hulu had also mentioned a bit of this, reflecting on work that has happened in HIV and TB. And I want to pivot this with you to you, Adila, just looking at existing models, right, of public-private partnerships that we have seen across other disease areas. What are some of those examples you could share with us? What have been the learnings, and how might we be able to leverage or tweak those partnerships today to suit the context of cervical and breast cancer? Adila.
Thanks, Nawira, and good afternoon, everyone. It really is an honor to be part of this panel on this crucial topic of public-private partnerships in healthcare. So if we look at the past, and as Nawira said, past PPPs, we see that they're emerging as very important mechanisms to tackle some of the pressing health issues that we're facing, not just in Africa, but worldwide. And this is because they give us the opportunity to bring together the strengths of both the public and the private sectors and combine our resources, our expertise, innovation in order to achieve common goals. So as I was preparing for this webinar, I did some research on which are the public-private partnerships that have been really successful and have had real impact in terms of what they've set out to do. And two came out that I just like to look at today and see, what can we learn from those two initiatives. The first one was is, because it's still working today, is the Gavi, which is the Vaccine Alliance. And this is a public-private partnership that aims to increase access to immunization in low-income countries. And we specifically saw the importance of Gavi during the time of COVID and rolling out the vaccines in countries such as Africa, where they supported us to be able to get vaccines and other resources that was required. And since its inception, Gavi has immunized over 760 million children. And in so doing, they've prevented more than 13 million deaths. So Gavi is a partnership which brings together governments, the World Health Organization, UNICEF, the World Bank, as well as private vaccine manufacturers and civil society organizations. And the success really lies in everyone coming together and pooling resources, which have resulted in lower vaccine prices being negotiated and sustainable financing for immunization programs going into the future. The other big successful story is, and I think a few of our speakers mentioned HIV/AIDS and the learnings we can get from that, is the Global Fund partnership. And this was funded in 2002. And they've invested over 45 billion in more than 140 countries. And once again, it involves stakeholders from across private and public governments, private sector, civil society, and affected communities. And their efforts have resulted in substantial reductions in the incidence and mortality rates of HIV/AIDS, as well as TB and malaria. And we've seen that playing out, for example, in a country such as South Africa, where we've got the highest HIV burden in the world. We've seen the impact of these programs. Now, just to look at some of the learnings that have come from these programs and how we can perhaps adapt this to women's health and cancer. So the first one is leveraging technology and innovation. The private sector could bring technological advances which present significant opportunities to enhance healthcare delivery in Africa. And if I specifically look at cervical cancer, we have advances such as self-sampling and HPV screening, which presents significant opportunities to be able to reach more women in Africa and treat more women in Africa in a more cost-effective manner. Also, capacity building and training. So a few people mentioned the need for education, the need for training of healthcare workers. And this is where PPPs can invest in training and education programs for healthcare professionals, enhancing their skills and knowledge in oncology and women's health and cancer. And we also heard community health volunteers being mentioned. And more community health volunteers are becoming part of these public-private partnerships where they are engaging and empowering communities, raising awareness, educating the public, and promoting preventive measures. To just maybe give you an example, BD has just rolled out a partnership with the Kenya Ministry of Health in the county of Nairobi to pilot self-sampling, where we've trained 700 community health volunteers to go out into the communities to educate women and to try and deal with some of the stigma around cervical cancer. We've also found that there's definitely a preference for self-sampling. And this has, well, it's early days, but we do believe that this is going to increase the amount of women that present for cervical cancer screening. Strengthening health systems, enhancing supply chain management, and ensuring availability of essential medicines and technologies. This is also where private sector can play a big role in terms of public-private partnerships. And then also importantly, something we should not forget is research and data collection. It's normally, private public partnerships that start up research initiatives to collect data, and especially in cervical cancer screening, we've seen how vital it is to understand what genotypes are impacting the African population, because this feeds into vaccine development and ensures that women are being sufficiently protected with a vaccine that covers the genotypes that we find are coming up in the African population. So once again, collaboration on research and data collection. And then finally, financial constraints. So this is often the critical challenge for healthcare initiatives in Africa. We all know that no matter what healthcare issue we're looking at, funding is our big barrier. Government budgets are often limited, and out-of-pocket expenses for patients in the African patient can be very prohibitive. So we've seen public-private partnerships such as the two that I've mentioned, Gavi and Global Fund, develop innovative financing models that leverage private sector investment, international aid, and local resources to bring about sustainable funding for programs such as HIV and TB, and hopefully in the future, oncology and women's health as well. Thanks, Nawira. Over to you.
Yeah, thank you. Thank you very much, Adila. And you really have brought out really critical points, right? And going back to what Mary said, there's no need for us to reinvent the wheel. How do we learn from what has worked best? And the examples you give are really tangible, looking at where we've come with HIV and AIDS and how through PPPs, we've made this tremendous progress to a point where we can see the reality that ending AIDS is really feasible by 2030 if we continue the investments that have been made. There is a point you made on technology, innovation, and HPV screening, which I want us to delve deeper about, knowing that HPV screening in itself, right, and the technologies we have are not always a perfect fit for our healthcare systems. What thoughts would we have when you think about technology selection, fit for purpose, and in the context of what is a tiered healthcare system, right, as we see it across the continent? How can we make a really enable communities be able to access HPV screening wherever they may be? Just your thoughts around that.
Okay, so I'll start and we can also hand over to the rest of the panel. So I think it's firstly critical to this is really understanding our communities, understanding what the barriers are, understanding, what is the size of the burden that we face, and then being able to tailor make our technologies to be able to overcome some of the barriers we face. We find that, in African populations, often access is a major issue. So for our patients to come to facilities to be tested, whether it's for HPV or for other diseases, is often a big barrier. And this is where, like I mentioned before, cell sampling becomes very important. In the time of COVID, we saw point of care testing playing a big role. And this is something for companies to think about. How do we make, when we doing our R&D and bringing about new technologies to market for Africa, how do we ensure that it's accessible and usable and importantly affordable as well? Going further into technology as well and how we can utilize this is when we develop our solutions, it's not just to think about bringing the solution to the patient, but also how do we ensure that we don't lose that patient? That once they've been tested and screened, that we keep the patient within the patient pathway, they're able to access treatment and they're able to go through the complete patient pathway. And one of the things that we as BD have worked on is how do we use mobile technologies to be able to track patients, to be able to communicate with patients, to be able to communicate with healthcare workers. A really good example of where this has worked well is in South Africa, where the Department of Health introduced Mum Connect to deliver prenatal and postnatal care to women. And Mum Connect is now being expanded into other areas of women's health because it was so successful to keep track of women, to communicate with them and to educate them. So, those are just some of the areas I want to touch on to make sure that our technologies are fit for purpose, to understand the communities that we're bringing our technologies into, and to ensure that they solve the barriers and the challenges that our patients and communities in Africa face.
Well, thank you very much, Adila. And I do like the choice of the word fit for purpose, right? So that we are actually looking at the burden of disease, but also from a technological point of view, when we think about deployment and implementation, we are cognizant of some of the barriers and thinking about it even before we bring those technologies into the markets. Thank you for sharing that. Still on that, I want to pivot a little bit and hear from Dr. Keegan. We do know that access to diagnostics across the continent has been a challenge, especially in Africa. And globally, we know that it's just about 2 to 3% of financing that's actually put into diagnostics. And when we think about breast and cervical cancer, I want to say, I think that even that level of investment is much lower than what we are currently seeing across all diagnostics. From your point of view, Dr. Keegan, what efforts and what is the government doing to ensure availability of targeted diagnostics, right? When we think in the context of breast or cervical cancer, what is the Ministry of Health in Kenya doing?
Thank you very much. I happen to be also the coordinator of the RSSH project in Kenya, global funded. So what we are doing is that we're working through different partners to ensure that we have resilient systems. We'll just cut across all aspects of diagnosis. In this aspect, we are trying to improve the labs to ensure that they have the capacity to be able to test and diagnose. Through this, we are able to get systems that can be able to diagnose. We also had the managed equipment system that was to help us in be able to get more diagnosis through the government. So as we continue working towards resilient and sustainable systems for health, we will need to work with partners. And this is when the PPPs come in. We need to work with different firms that offer diagnosis and see how best can we work together to be able to reach access through the 47 counties within the country. So currently now, most of the labs, the National Public Health Laboratory Services, are expanded into 8 regions. So once we have these strong 8 regions, it means that the samples don't have to come all the way to Nairobi. They can actually be done within the ecosystem of the counties. Second, through the financing, the new financing system that we have, the SHA system, we expect that we'll be able to fund both private and public facilities in the treatment diagnosis of cancer, both cervical cancer and breast cancer. So as a country, as we introduce the new bills that are helping in the financing, we're trying to see how can they be able to be accessible through all regions, all areas of accessibility. So that's how we are working as a government to just ensure that everybody has a right and to the right diagnosis and the treatment of cervical cancer. Thank you very much. Back to you.
Thank you. Thank you very much, Dr. Keegan. And it's really good to hear what we are doing and how we are leveraging already existing systems in Kenya. On Monday morning, I did have Wednesday morning, I did have the opportunity of attending the WHO private sector roundtable. And in that discussion, we actually did hear from the governor of Laikipia, also looking at what modalities could be employed to ensure that we can get diagnostics to the county level. And he did actually weigh in on the MES, the Medical Equipment Services Project. He also did talk about partnerships being very critical to improve and strengthen the lab infrastructure, which then supports the whole ecosystem. So I think this approach where we have the county as well as the national government moving all together sounds like the right recipe that would really help us be able to increase access to diagnostics much more broadly and not just on breast and cervical cancer on its own. Thank you very much, Dr. Keegan. But that triggers another question for me, which much more leans on the side of industry. And Hulu, I want you to weigh in here. Listening to the discussion with Dr. Keegan, where we are talking about innovative ways of making sure we can bring in diagnostics and make them more accessible. Also reflecting on the World Health Assembly resolution in May 2023 and the movement of the countries towards actually establishing the essential diagnostics list. What are some of the thoughts or ideas that you could share with us that countries could be thinking around, and we as industry, when we think about increasing access to diagnostics, but also helping the countries begin to implement and bring to life the WHO resolution on diagnostics? Hulu?
Thank you. Thank you so much. And thank you, Dr. Keegan, and the other speakers that have spoken. I think the one thing that was on my mind before you asked the question that I also wanted to congratulate, I think, Kenya on is just on the, on the leadership, right? So we see, even from the First Lady of Kenya, Her Excellency, even with the program that she has on Mama Doing Good, she's very much vocal and also working with some of the county women governors in terms of them reaching out to their communities to ensure that education still continues and more women actually screened. So I think it's, political will is something that is also required. But coming to the question on the innovation of diagnostics, I know that, Abbott, similar to other multinationals who are members of COA, what we have done is to really to listen, one, to the public sector in terms of what is needed, and placed some of the equipment in the decentralized and also in the central labs, and also, took out, placed more, I'll call it innovative. I don't want to go much into the product side of it, but, that as companies and private sector, we can innovate more, right? By placing equipment that not only, for example, can do HIV, but can do also HPV screening. And what this would allow, if you have equipment that is sort of like multiplex screening for infectious and non-infectious diseases, it also then allows you, when a woman walks into the clinic, right? So you then are able to take, a variety of samples from them, and you are able, with that one or two samples, to test for so many things. So I think that is, that we need to just make sure that also we are maximizing the patients once they are already coming to the clinics. Let's just make sure that the diagnostic tools that we are putting in all the facilities, both in the central and decentralized, and I also heard someone talking about point of care, they need to be put across the range of the primary sector. But then let's also make sure that, we then give the women a holistic diagnosis, right, in terms of their health. We look at their health in a whole, make sure that you are testing not just for, if it's you're not just testing for HPV only, but we are testing for other diseases. But then the diagnostic solutions, which are also placed, need to talk to that as well, which then would also probably talk to the funding as well. So I think there needs to be more focus in terms of women's health, women's health funding in a way, not like disease specific, but if we can think of what are the diagnostic solutions which are required for the high prevalence of diseases that are facing women, and can we now start having funding, even whether it's from NGO, but also in the countries, just for women's health. And we have more women's health clinics, right? So not disease type clinic, but women's health clinics. And then that on its own, would just then represent easier access to more diagnostic tools, but easy access to also the results that the women can get. I think the diagnostic solutions that are also being put in all these facilities, it's one thing to test and have the right diagnostics, but it's the other in terms of how soon those results are coming back, right? So, we need to be very sensitive to patients, to a patient who has done a test. If you're going to go back home and still wait for 10 days without getting your results, that is just torture on its own. So how can we even improve the turnaround time of those diagnostic solutions that we have, so that the results can come out quicker, so that one can know what their status is, and also then be sent for treatment if treatment is needed. But I think here, Nyawera, what I would like to do is also bring in the use also of digital, right? So the digitalizing the concept of healthcare as well, in terms of let's use and leverage this digital also connection for the either the treating doctors or even the patients to have access to all this information in a quicker and easier way and in an informative way in order for us to decrease the prevalence that we need to decrease so that we can start, we can start celebrating some wins in the next few years. Thank you.
Thank you very much, Hulu, for sharing those details and really, weighing in on the current existing infrastructure and how we could also leverage on that to increase access to diagnostics. I mean, you also know, just as Abbott Hologic is also a major player within the HIV space, and therefore looking at multi-disease testing platforms, how we integrate more from the vertical programs into ensuring that more women that are actually outside of the vertical programs do also have access to these technologies that can do multi-disease testing is a question that we need to be addressing here. Which brings me to you, Mary, and I just want you to weigh in. When we think about the integration, right, we are talking about vertical programs, heavily leaning on only HIV and TB in this case, but where significant investments have already been made. Today, we do know that women living with HIV do have access, for example, to HPV screening using that type of setup. What are your thoughts on, and if we think in the context of integration, in your point of view, now that you work within the cancer control program, how can we bring about that integration? Are there any gaps or barriers that we need to override to ensure that, one, even as we build this solid diagnostic infrastructure, we are leveraging on what already exists in the countries? Dr. Mary.
Government Productions in partnership with the National Theatre and Joy Fair presents a roller coaster ride of a
Okay, thank you very much. So for leveraging points, I see that there are quite a number of leveraging points that we can be used. In terms of digital solutions, for instance, since that was just mentioned, there are cases where, for instance, in Ghana, there are digital solution providers that find themselves in the private sector space. And currently, our PPME unit, the Policy Planning, Monitoring and Evaluation Unit, is working closely with through their IT desk with private sector providers as we seek to look for digital solutions for health. And this has sort of escalated the IT innovations that prior to that engagement was relatively limited. Things such as mHealth, telemedicine, all the e-health solutions that you can think of are quite well advanced in the private sector space. When you move into the government space, they are relatively on the low. So I believe that once we're able to form these collaborations with the private sector, we will be able to take advantage of the digital solutions that they offer. Ultimately, it's the population that must benefit from our interventions. Beyond that, too, there are quite a number of projects that multiple pilots have been done in the space of women's health. Very recently, there was a key collaboration between the Ghana Health Service, Roche, and Njipaigo on a women's health initiative that was undertaken in one of our districts. And it looked at community mobilization, it looked at screening using HPV DNA testing in addition to the routine VIA pap smear. And the response was huge because the private sector components largely targeted the community angle of care and ensured that they are liaising directly with our district assembly, they are liaising with women's groups, to mobilize and create demand for the services. Prior to that, I doubt if the health system itself could have created that much demand for breast and cervical cancer screening services. But since the other partners came on board, a lot was able to be done at the community level, and that created huge demand. The other side of it is so when we look at the funding component of care, I know we'll come to funding much later, but once other parties come on board, then we start to look at locally available resources and how that part of the wheel can also be turned. In that, resource mobilization in the private sector component is key. Now they are able to adopt much more innovative strategies and carry them through relatively as compared to the government sector. So as I said, there are multiple leveraging factors. And then finally, from my end, I think that government systems are available to be used. And they just create this huge opportunity for us in order for us to expand our reach. For us, the health system structure, looking at the primary healthcare, the secondary, and then the tertiary, the primary healthcare is so well established and able to reach the farthest communities within the country. Once the private sector also hops on board, they are also able to expand their reach using the established systems, using the health providers that are already being churned out through the government systems as we have. So I see the partnership can be a win-win for both sides. For the government sector, we only stand to gain from my part. And ultimately, this gain must translate into improved services for the women that need to access the services that we provide. So there are quite a number of leveraging activity, and probably finally to the other ongoing programs that are successfully being run, and the wheels being oiled by the private sector component provide huge learning opportunities for us that we can take advantage of in order to ensure that we improve on the services that we provide, be it screening, be it treatment, as well as other innovations that we can take advantage of.
Great. Thank you very much, Dr. Mary, for really weighing in and really bringing out that private sector has made significant investments, and it is how we continue to leverage on that to strengthen women's health across the continent. Dr. Keegan, I hope you're still with us, because I know, and I just want to go slightly back into leveraging existing technologies that actually have been effective in other programs. And I know previously you did actually work within the HIV hepatitis program in Kenya before you pivoted. What has been your experience, and where do you see the nexus where these two come together? And are there any barriers, or what is it we need to do more to ensure that this equipment that's been invested for HIV and TB can actually be accessible to provide service and care to many more women, especially in the context of HPV screening? What are your thoughts, Dr. Keegan?
Thank you very much. Within the ministry now we have a department called Resilient Sustainable Systems for Health, which is funded through Global Fund and the World Bank and the Ministry of Health itself. So when this program going to be more open and more wider than just the three programs of HIV, TB, and malaria. So in the RSSH system, we are trying to ensure that when we get these platforms, they're able to do almost everything that we are able to do in terms of disease monitoring and actually diagnosis. So I think if we work with the other partners and really make sure that we have platforms that are interoperable, then we're able to get out more from the systems that we have, rather than just being really parallel on its own. So I think this is a long way we're going. We're talking about systems that will be sustainable and resilient throughout the processes. So as we work on trying to ensure we have access, we can use the platforms that are already there on the ground, but make sure that are interoperable. Currently, we are supporting the community, the lab, the disease surveillance, to be able to just give us a clue of how they can be interoperable in terms of they're not just the.
Sorry, it's just the National Service, NSMQ, that we are interviewing. So we should be done soon.
Hello? So thank you very much. So in that system, we also want to ensure that we also look at the IT system. and ensure that they are interoperable in terms of the systems that we have, the lab the pharmaceutical system, to make sure that they're just interoperable and be able to access all these things through the same system, that it's already existing. Back to you.
Great. Thank you very much, Dr. Kigen. And I know I put you on the spot on this one, but because I know you've had the occasion at least of working across the two programs, and it's really good to hear that we are actually integrating, leveraging what we have to ensure that we utilize already resources that have been invested in. Massive investments have been made in HIV, TB, and malaria. And how do we leverage that to leapfrog as we think about cervical and breast cancer? And one of the things that also has come out of this discussion is really around the role of human resources, and this is healthcare workers. And I also did see it actually posted on one of the questions on the charts as well, that really at the core of what we are doing is the capacity building, the capability of the healthcare workers to actually be able to deliver that service, whether it's creating the awareness, whether is when they meet me for the first time as a woman, being able to ask the right questions to understand what I need as a woman, or whether it's actually being able to put me through the whole pathway of getting screened, diagnosed, and treatment. And I think it's also very apt when we think about when we celebrated the 4 years of the 90-70-90, it was really themed how we elevate frontline healthcare workers, because they're the ones transforming global commitments into life-saving actions. Dr. Kigen, again, just a quick reflection on healthcare worker capacity building. I know we did hear a little bit from the side of what we as industry have done in supporting capacity building, but when I reflect on Ministry of Health, where do you see the gaps, especially when we think in the context of screening, sample collection? In the context of breast cancer, we need higher pathology testing, right? Where you get a biopsy and you have to go through the whole continuum of tests. And then also when we think about access to treatment as well, what are the gaps that are currently existing? What is working? And what more can we do? And where do you see private sector playing a role to help you close those gaps?
Thank you very much. Back to me, I know. So quite a number of things have been done. First of all, we know that we did train trainers of trainers, but there's a lot of, in terms of health workers, the execution rate and the transition rate is quite high. So we need to keep retraining them in service at both levels of the county, the sub-county, and the facilities, in both screening and early detection. So this is where the gap comes in. We need to work together with the partners. We've done quite a way in moving forward, but we still need more partners to support us in this. Two, in the high-level training, we did have we've done both our staffing needs, health staffing needs, and of course the labor market analysis, and just looked at the specialties and see where we are in terms of as a country. As much as we have increased the number of oncologists and gynecologists, we still need more training, especially in sample collecting. Like pathology. Pathology is actually where we're one of the lowest cadres that we need to train more through support of different people. If we can have more training of this staff, then we can have better diagnosis and better analysis. Second, sample collection. Most of this time we may need to do in-service trainings of both the lab people and the clinicians. So for me, as a country, we are trying to do as much as we can, but we need to work with partners. We've worked with several partners, and the private sector should also just pop into this and help us support us in able to have this staff fully trained. So as we continue trying to improve the health workforce, we still need a lot of support from outside. It's a big, broad area that we have to go down up to the level of the community. The community health workers, they must know what they need to do. As we're establishing the primary care networks, currently we are at about almost 190 of the expected 313 that are fully established and functional. So I wish that the partners, the WHO, UNICEF, all the private sectors can actually support us in establishing these primary care networks. Thank you.
Great, and thank you very much, Dr. Keegan. I know the issue of human resources for health is really broad, right? And I did not expect that we can fully cover that, but the nuggets that you have shared with us here, truly identifying the gap that we have, especially on the pathology side, and also the capacity and capability, I think begin to frame the next discussions we need to be having as a wider stakeholder to say, is there anything that we can actually be working around? But I also do think that there is a role that technology can play to bridge, for example, the healthcare workforce gap that we see. We've heard about AI and digital technologies that can actually step in to be able to help us bridge that gap. I know, for example, we at Hologic have integrated artificial intelligence, and we're moving towards what we're calling digital pathology as well. Cognizant of the fact that we don't have sufficient pathologists and we will not be able to train pathologists overnight. This is a 7-10-year type of program, but we also as industry can think about those innovative solutions that actually help us bridge that gap as we strengthen our healthcare workforce moving forward. Digital technology, again, going back to where you started on information, the data, the evidence that we need, the interoperability that we want to have to also enhance evidence, right, that we need to do, collect the data that then can support policy and help us leverage and move things forward. One of the elephants in the room, and I know this has come up earlier, and I know Adila did weigh in a little bit on it, was around financial burden that we need to be thinking about and where the money is coming from for all these ideas we are talking about. And that, for me, financial commitment also is tied into the political goodwill that we are also talking about. I see the two of them as being inseparable when we think about how are we, putting out resources to support some of these ideas that help us continue to improve women's health. Dr. Mary, I want to bring this to you for us to discuss what innovative models of funding or financing have been utilized before, or that we could think about that will help us, one, get greater investments into women's health, and what should countries and governments be doing different? Again, going back to the discussion around a women's health type of financing mechanism that Hulure did mention much earlier. What are your thoughts, Dr. Mary?
Thank you very much. The issue of funding is always an interesting discussion, in that from both a policymaker and an implementer point of view, you sit at the table where you see what the patient is going through, you realize the difficulties that are associated with out-of-pocket payments and ultimately leading to loss, patients being lost to care. At the same time, you see the component where policies are supposedly made that should ensure that these services are enrolled on, let's say, the National Health Insurance, despite the fact that the policies are available at the service delivery point. The policies are not directly translating into availability of services or ease of access to services. And that, for me, is a huge gap, in that for conditions that are supposed to be covered by National Health Insurance, clients still need to make some kind of out-of-pocket payments once they are being attended to. And that's regardless of how small that contribution is. When people especially are very much impoverished and you introduce any cost component, it totally dissuades them from accessing care and thereby increases their preference for alternative medical solutions. Now, despite this, there are conditions in our setting, like childhood cancers, for instance. Prior to National Health Insurance enrolling some of the childhood cancers on board, we had local funding mechanisms that were adopted by our treatment sites. Now, these treatment sites had local funds that were supported sometimes by some district assemblies, some survivors of childhood cancer. So there are some churches that routinely donate into these local funds, such that all the parents had to do was to get the child to the treatment site and the treatment was taken care of. Now, with all the advocacy and wanting to get the cancers taken up by the National Health Insurance, and finally succeeding with there was a lot of political visibility around it, and finally we got our top 4 childhood cancers taken up by the National Health Insurance. The flip side is that now the alternative funding support has dwindled massively. So in people's minds, now the government is taking over, so we don't need to support anymore, forgetting that despite the mainstream care, beyond the chemotherapy, radiotherapy, there's so much that's also going into supportive care, nutritional support, physiotherapy, you name it. And these might not necessarily be covered under the mainstream level of care. So when these alternative funds, which could have been used to provide a more holistic care for the patient, but then when these alternative funds now start dwindling, then unfortunately the patient and their families would have to take up that part of the care. Therein lies our out-of-pocket payments. So we are sort of reverting to the earlier position where out-of-pocket payments were high, despite the fact that the National Health Insurance has come on board. I believe that for women's health, so in as much as we all want to work outside of donor supports, it's critical. We have seen how donor support has sort of been a catalyst to propel a lot of interventions in the maternal and child health space. If you are talking Global Fund, for instance, HIV, TB, malaria, and that catalyst is what it has been lacking in women's health for a long while, specifically if you look at breast and cervical cancers. We've set up these 90, 70, 90 targets, and some way, somehow, countries are expected to figure out the how by looking at our health budgets and looking at how little funds are, if ever, directly provided to support women's health. I'm not sure how realistic these targets would be when there's no dedicated funding, if for nothing at all, just to screen. And then the alternative sources of funding can also be looked at. So for the gaps, there are quite a myriad number of gaps available in terms of the funding. The other component too actually has to do with, let's say, these economic evaluation studies that at least within Ghana has been lacking for breast and cervical cancers. How much is it costing the country nationally? How much of our GDP is going down as a result of all these late-stage cancers that we are reporting? That information is what would push the politician to know that if these number of women, I'm losing them to cancers, it's not just about numbers. There are lives behind them. And beyond their lives, it is costing me this much, such that ultimately even my votes are going to be affected. I believe the availability of economic evaluation studies, locally relevant economic evaluation studies will provide a good tool to be used for the advocacy to ensure that women's health are fully funded. It is something that we cannot do without it, but then we cannot also just sit and expect that automatically women's health will be taken up by some system. We need to be deliberate in designing, in looking at the financing for women's health, and with that, a huge chunk of our health burden will be taken care of. Thank you very much, Enova.
Thank you very much, Dr. Mary, and you raise really pertinent issues around the complexity of financing, right? Coming from a situation where we have been dependent on what you're calling now alternative financing, which we know is really what has been done by the donors that support the African health care system, and by and large across multiple diseases. And I like the thoughts you're having when we think about women's health and all the work that we are doing. What I see, and this is my personal reflection, is that we are doing quite a good job on the advocacy side, raising awareness on the need on why we need to invest in women's health. And it's a no-brainer. And sometimes it feels like nobody's really hearing this story, or even the data and the statistics don't really seem to be getting probably to the right people for them to be able to make those right decisions insofar as investments are concerned. Sometimes I think we are speaking to the same people, preaching to the choir, all of us that are already there. But you did bring in the angle of the politicians, because in the context of African governments, we do know that the budget making process really lies with the politicians within the parliaments, right? In the context of Kenya, we have the Parliamentary Health Committee, for example. There is the Department of Health within South Africa as well, that really then determines how budgets are being, how money is being distributed across all the different priorities that governments do have at that particular point. I do like the economic evaluation studies that you're talking about and how we need to work around that. I don't know if you have any ideas on how we can increase domestic financing. I mean, the realities are here with us, whether we are talking about HIV, TB, and malaria today and the future, or even thinking about the expanded program on immunization, whether we think about maternal, neonatal healthcare. Everything is beginning to shift to what you're saying. We have goals and targets that we must achieve, but we have to figure it out ourselves. From your experience, and this may not be necessarily your strong zone, and this is for all of us here as panelists to weigh in, what are some options we have, right, that we could be pursuing to increase domestic financing, right, towards women's health? What should we be looking at? If we were to meet with the Parliamentary Health Committee in Kenya, for example, what are some of the proposals we could put onto the table, saying that we are looking at these as potential pathways for us to ring fence or generate more funding towards women's health? And Mary, maybe I start with you, and then I'll go to you, Hulu, to have your quick weigh in on that, and then Adila after.
Certainly. Thank you very much. So my favorite word is what you just talked about, the ring fencing. And in dealing with some of our partners in the Ministry of Finance, that also seems to be a word that they do not really want to hear. Ring fencing funds, because ultimately it just means that you are increasing the demand for the already available limited resources. But at the local level, I think that the advocacy, okay, so as a personal opinion, I feel that a lot of the advocacy has been unidirectional and targeting the higher level policy makers, the various ministries of health. At the other end of the spectrum, where you have the community, it's essential that we also increase the advocacy there. Ultimately, it is the community that is going to create the demand for the screening services. And it is the community that must see the need to ensure that the women are made available to come for the screening. Now, that same community also has some resources. In terms of CSOs, in terms of NGOs, there are also local government agencies that sometimes have some kind of funding for health interventions. But then when our advocacy does not target these components, then it becomes a bit abstract for them. It's the health people that have started their noise making once again. So we leave the decision to the woman, whether she wants to go or not. But then I believe that at the community level, just as we are able to really mobilize people to come for screenings, we should start mobilizing for resources. And these resources can target local communities. So if a specific district, for instance, has put some funds available to support any woman that develops some kind of cancer, they don't need to pay for the treatments, but if they can support, let's say, the transportation services, or they can arrange with the local transports organizations, that every woman that has an issue, a specific issue, would rely on you to transport her to this particular place. So those locally available resources, I believe, have largely been underestimated. And once we whip up enough sentiment at the community level, they will start making demands of their political representatives that, you know, this has been happening. How come you are not pitching in to help? So I believe that the local resource mobilization, it's key, and it's something that we can rely on. But I foresee that the local resource mobilization is largely supposed to be complementary. It cannot be like the main gamut of funds that we can place on the whole cancer prevention spectrum, but then it can come in as an adjunct to support the provision of services.
Thank you. And those are really brilliant ideas, thinking how we can bring in the community, right? And I think I did share that on Wednesday when we were at this WHO roundtable, we also did have from the Kenyan countryside, we did have the county of Kajiado represented there. And it was really interesting to hear what Kajiado County is doing, where the governor shared that they do have this concept that they're calling the one goat for a health cover, right? This is within the Maasai community. They do have some resources in the shape and form of goats and cows. And here to really bring about universal health coverage, they have then started to localize the whole concept of how can you get medical insurance or be able to access health. And they discuss with the communities the whole concept of give us one goat, and this is what then you would be able to get in return from a point of, you know, medical cover or medical access. So very interesting, and thank you so much, Dr. Mary, for sharing that. Hululue, any thoughts on what we can do to get more funding into women's health?
Yeah, so funding is all, you know, it's not I almost wanted to say it's a hard topic, but it's a key topic, right? Because without funding, we cannot do all the screening that needs to be done. I think even what we need to start with, right, as we understand that there is just so much high prevalence on this, I think on a government level for every country, we should not make we should not come up with solutions on how to lower this prevalence, and now specifically speaking of cervical cancer, only with the health sector. It requires us to also invite the health economists, but also the finance ministry, right, of every country as well. So at this stage, I'm just now shying away from, the donor funds. I'm just talking about the funds, the country being aware in terms of how it's spending its healthcare budget or how much it should take. So I think what we need is economic models that will start showing in terms of what is the burden in a country of not treating cervical cancer, right? So how much of the public funds end up being spent, right, of treating women who would otherwise then have cancer and then come to the hospital or even go to hospice. So, or even their lack of economic activity, going to work, all those things. So it needs like an economic and a proper economic model, and show that this is how much money is being wasted. And also then that also should talk to, if we were to inject X amount of fund just in the prevention and screening, therefore, the country will be saving X money. And that, I think, if a country can start doing that, that on its own would be attractive, I think, to those who would fund, right? So the external funders as well, who would see that, countries have done their homework and they themselves are putting some funding into this. But I think there was one speaker that also said that, we should also find a way of, patients somehow as well, putting something into this, so that it's, it's everyone, and it's somehow inclusive. So yeah, so I think the key for me is just making sure that we do some modeling to show that if we are not funding this upfront, how much money is lost, and funding it would actually generate, if more women are able to be economically active, that on its own, it can increase, right, the pie in terms of the money of other things, and they'll be able to spend more money, be going to work and all that. So hopefully, that is clear. But, I didn't think of the funding question in depth, but that is, my go-to answer for now. Thank you.
No, and thank you very much for sharing those thoughts, right? We are all trying to find potential options, solutions that we can be bringing to the table as we think about advancing the investments that we need in women's health. And I do agree with you and Dr. Mary that really evidence is a critical piece to help us be able to drive that. But we do know that there's already some data that's available, right? The World Economic Forum, together with the McKinsey Health Institute, did actually produce some data. And if you reflect on it, they actually say that investing in women's health could boost the global economy by $1 trillion annually by 2040. So the case to make the investment is there. Definitely, there are challenges, especially in the context of low to middle income countries, on how we make those investments and support women's health going forward. But absolutely, I think localizing that type of study, what does it mean in Kenya? What does it mean in Ghana? Might be some form of evidence we need to be able to present to the ministers of finance and these politicians that are making the decisions on how much money is invested in health. Adila, any thoughts on health financing, this hot topic?
Yeah, so I mean, I completely agree with Dr. Komi and Kululiwe's responses. I think the answers lie in, firstly, increasing advocacy around women's health. We know that there's a big inequality gap when it comes to men and women, and it's not just in Africa. It's around the world. I mean, for example, Nawira, the same study that you've just quoted now, the same report also talks about in Denmark, where, they across 21 years, they showed that women were diagnosed later than men for more than 700 diseases. So it took them 2.5 more years to be diagnosed with cancer than what a man gets diagnosed. And, the 1 trillion rand or $1 trillion in savings that you speak about, this is just to close the inequality gap. If we were to close that 25% inequality gap between men and women, that's what it could mean to the global economy. So definitely, I think we need an increase in advocacy so that, women's health becomes prioritized and focused on, and then understanding the health economic burden of not prioritizing women's health and not doing anything about the problem, that we have in front of us. Might shift the needle, without having to get additional donor funding, etc., but just to kind of, shift around the funds that are there and prioritize women.
No, and thank you very much, Adila. And you actually bring in a very good point, right? Even when we think about investments, whether in health generally and in women's health in particular, even in this discussion we are having, you will see that a lot of our governments are much more leaning towards the end process, right? We are thinking about, getting into PPPs to ensure that treatments are much more cheaper, right? To ensure that we can actually be able to get surgeries and biopsies much more cheaper. But when we come to the space that's promotive, preventive health, we seem not to be making those significant investments. And again, going back to the evidence that we need to be putting onto the table to show that when we prevent disease, we are actually saving this additional, down the line cost that then countries have to bear when women come in terminally ill and have to, go through terminal care, survivorship support. And of course, we know the loss of life and the impact of loss of life of a woman that it has not just on the family, but well as a society at large. So I think really putting together this discussion around amplifying the need for investments into preventive and promotive care. I'm cognizant of the fact that we cannot totally, thrash out the issue of financing in health as is concerned, but this discussion begins to pave some high-level way of thinking in terms of some of the things we could be doing, ideas that we could be working on in our respective spaces and also within countries to drive the dialogue around women's health and the need for more investments. Thank you very much for your reflections. On my side, I want to pivot to some of the questions that we may have from our attendees on the webinar. I do have a couple of questions that we can actually respond to. I see a question here from Amelia Frederick, and the question is around, are there digital tools for self-testing for cancer, for example? And I think here, Hulu or Adila, if you can weigh in, do we have digital tools for self-testing for cancer?
So I can maybe jump in here, Nawida. So one of the tools that we are looking at developing is a digital tool that is able to track the woman through the journey and communicate with her in terms of what her result has been. So I'm not sure if that is the type of digital tool Amelia is speaking about, but that is one of the tools that we're developing to support cell sampling. So that women can take a sample, the sample gets sent off, it's linked to her on the digital tool. So when the result comes back, she can be communicated with digitally and told what the result is, and then navigated through the patient journey depending on her result.
Thank you, Adila. Any thoughts, Hulu, on digital tools for self-testing for cancer?
My answer would be literally the same as Adila's.
Okay, great. Thank you very much. I think I can add my voice onto this because I think there's something I've seen that United and I think Chai was working on, right? But this is not on self-testing. It's still going to be done by the clinician, but also looking at how they can improve actually visual inspection. And they have applied some digital tools around it to improve the visualization and therefore then improve the specificity and accuracy of that particular test. But I'm not aware of digital tools for self-testing that are available currently, Amelia, and that's an area for us to scope out and either work on from an innovation point of view, but also find out what else is happening much more broadly. We have another question from June Omola, and I think actually this goes to something that Dr. Mary actually talked about. And June asked that she is looking for more insights around nutritional support for cancer survivors. Do we know of any programs that do either nutritional supplements? And also, is there anybody working around how to bring down or break down the myths and misconceptions around this? Dr. Efwe, I know you did talk a bit about nutrition as part of holistic cancer care, and maybe you might be able to answer this question that June has posed to us.
Certainly. So thank you very much, June, for that question. Once again, I will come back to the childhood cancer space where we worked with some private sector entities that they made these nutritional supplements. So initially they were making nutritional supplements for malnutrition. But then with the childhood cancer program collaborating, then they came on board to provide nutritional supplements, not just for persons who were receiving treatment and then continued on to survivors in that post-treatment phase to these nutritional supplements were provided for a certain period of time. Now, this collaboration was done with one of our key treatment sites, the Greater Accra Regional Hospital. And survivorship, quality of life markedly improved. The findings are so interesting to look at. And it's something that I believe we can always look at to have massive learnings from what has happened in the space. But then, yes, this collaboration has happened for us in the childhood cancer space. And it was largely the supplementation was provided by the private sector entities for the patients who were being taken care of by should I say, the government facilities. So yes, it does exist. And then I think she also talked about myths and misconceptions. Okay, so mine was the first part. Somebody else can take up the second part as well. Thank you very much.
Dr. Keegan, if you're with us, you can weigh in around nutritional supplement support for survivorship.
Thank you. Thank you very much. Yes, there's a lot of nutrition support that we do give through the programs. In the ministry, we have the Division of Nutrition and Dietetics that actually works with different nutrition support units that work with the counties. So I think for us, we just need to maybe coordinate and see the counties if they can be able to work with the teams that work together. Because when we are doing it, it's actually under family health. It's a whole thing that covers issues around family health from childhood to adolescent, reproductive health, and includes also the nutrition support systems.
Thank you very much, Dr. Keegan, as well as Dr. Mary, for really helping us understand the context of nutrition and nutritional support. I hope, June, we've been able to sufficiently respond to that question. One more question coming from June as well, and is really looking at how we can borrow from the HIV program. And her question is, do we foresee governments having the rapid response initiatives for cancer testing? Dr. Keegan, I want you to weigh in on this because I know you've worn both hats, right? You know about the RRIs within HIV. Do we foresee a possibility that we can see RRIs for cancer testing? Dr. Keegan?
I'm back. I'm there with you. Can you hear me?
Yes, I can hear you now.
Yeah. What happens is that RRI is when you are below targets. So we normally do an RRI when we realize we are below targets. So that is determined by the programs. As far as a ministry, we have our performance contracts, which include the accessibility to screening for cancer is one of the performance contracts, which is captured through the National Cancer Institute. So when we realize that we are behind, then we need to really do an RRI, then that can be initiated. But it has to come from results and initiatives by the mother programs together with the partners. For the last really about 6 months, we've not done any RRI because we have been on point in most of the screenings. So we need to look at it again. Whenever you're behind, then we do. Back to you.
Thank you very much, Dr. Keegan. And I think you've really put in together the concept of RRIs. Most people who have worked within the HIV program definitely do understand how RRIs work, and it's really a catch-up when we are behind targets. So again, definitely, as the theme has been all through the webinar, is we don't want to reinvent the wheel. How can we leverage what has worked in other disease areas and be able to utilize it within the context of breast and cervical cancer so that we can actually be able to drive this forward? I don't see any other questions unless Elizabeth and the team, there are other questions that the panel can respond to. Those are the only 3 that I had. Do we have any other questions?
No, but I think a panelist has their hand up. Somebody, yeah.
Yeah, let's go on. Let's take that. Elizabeth, do we have somebody's hand up? I cannot see everyone on my screen.
So we'll allow him to speak, just a minute.
Yeah, hello. Good morning.
Good morning, Abduli. We can hear you.
Very well. Thank you for organizing this a very good meeting with partners. I'm speaking from the Gambia, and one of the things that I want to add on to this very fruitful discussion is that how can we involve men to make a research to look at men's attitude towards cervical cancer? Because we are parents, we are husbands, and we need to really guide and help our wives and our daughters to make sure that they go into screening, and then that when it comes to the treatment and management, we also help them to the end. And also looking at the healthcare workers, we need to capacitize them, we need to train them on cervical cancer screening, on counseling, pre-counsel and post-counseling. All those things are very much needed in our health system. And also, it's not only cancer that is really affecting women in the continent, but also looking at hepatitis B related to HIV and TB and syphilis. In the Gambia, we are trying to make a triple elimination campaign, looking at HIV, looking at syphilis and hepatitis B, and also looking at the transmission area of mother-to-child transmission, and try to boost the hepatitis B dose vaccination. So these are some of the challenges that really we are struggling in the Gambia here to see how best our health system will be supported by partners and private area to see to it that the capacity of the health workers are built, and many testing test kits and the reagents are also available for our labs to have the capacity to be able to test for cervical cancer and also hepatitis. Thank you, and over.
Great, and thank you very much, Abduli, for that feedback and really weighing in also on the role that men do play, and especially within the context of the African society, where more often than not, they are the pass holders. It is actually something we must remain cognizant of, that we need to be working not just within ourselves, but also that we are working across all different key stakeholders, and in our context, also carrying the men along as they do enable that process. Very valid point, Abduli, that all of us do agree and accept. It does help us to reach out and win this war together collaboratively. Elizabeth, any other questions? I don't see any other questions on my end.
No, any other question? I think we're done.
Great, and thank you very much. And this is just a quick reflection. I hope that all of you have had the opportunity to listen in and see how we can leverage what is currently working and then begin to build on it as we move towards the elimination goals by 2030 for cervical cancer, but also towards meeting the Global Breast Cancer Initiative targets set by WHO. On my end, it's been really interesting and illuminating to reflect back on the role of public-private partnerships, right? And how they play a significant role from awareness creation at individual community level, to getting the women to come in for screening, to supporting the diagnostic infrastructure that is required for screening, supporting education of healthcare workers that are needed to actually be able to carry out the screening, and moving into treatment and care, where we need to provide the technologies, support the healthcare workforce capacity for us to be able to move towards the elimination goals. All those touch points, and also learning back on what has happened within HIV, the immunization program, TB as well. We do see that alone we cannot go very far. So private sector cannot work on its own, public sector cannot work on its own, but we do have models that we can actually reflect on, where public and private have come together and made significant differences. And it was good to hear, along the immunization program, what we've done with childhood immunization, and then catapulting that in terms of the gains we have made on HIV, AIDS, and TB, as well as malaria. Healthcare workforce as well, and the role that the private sector can play, absolutely. There is the in-service, post-service training piece where we can actually be able to leverage the capabilities and competencies of the private sector to be able to enforce and strengthen our healthcare workforce to be able to respond to the current burden of breast and cervical cancer. Financing remains a big challenge, which are the ideas we're all trying to put out here. And it is good to lean in and say, yes, we have private philanthropy that does come in to support some of the gaps within the government, but also looking at how government policies, the infrastructure around financing can be built to ring fence some sense of financing that would then go towards supporting women's health. And the big piece for me was on evidence generation. All of us here, and especially under the Coalition of Women's Health in Africa, one of the key things we want to do is generate that data and evidence and really become the advocates for improving women's health in Africa. So we cannot really overstate the role that the data and evidence will play. And I did hear the need for us to bring down this global health economic data to country level and be able to put it into the hands of our politicians who are actually determining how budgets towards health and other priorities within governments is being done. And I think in that space, we'll then be closing the whole loop of policy making, not just doing advocacy, but following through with chasing the money that we then do require to implement some of the policies and guidelines that have already been outlaid. So as we come towards the close of this particular webinar, I want us to reflect on a couple of things. And this is what came out of the ABCDO study that was set up to examine the determinants of breast cancer survival. And this has been done across 5 African countries. And really the data there is so compelling to the need for us to act now towards preventing any further mortality that comes from cervical and breast cancer. The first finding there revealed that half of breast cancer deaths that occurred in women in those 5 countries were younger than 50 years. So it means breast cancer is taking women when they are at their most productive age, again denying us the possibility of having these productive citizens contributing to the overall African economy. They also did find out that on average, each of those deaths created 2 maternal orphans. Again, having children being raised without their mothers as well. And we know the impact that has, not just on the family, but the society as well. And another finding was that families that were actually dealing with women who was suffering from cervical and breast cancer really were concerned about the future of the children because of the catastrophic financial expenses that come from the out-of-pocket issues that Dr. Mary was discussing, which is associated with cancer care and treatment. So our work is not done. We here in this webinar and also across the world, as well as within the continent, we must continue to fight breast and cervical cancer and begin to ensure that we can improve the well-being of our women and girls. And thank you very much for tuning in and for all your input. Back to you, Elizabeth.
Thank you very much. Thank you, Nyawira. Thank you for this wonderful session that you've had. I would really like to take this moment to appreciate all the participants, all the questions, all the engagement you've brought on the chat box. I think some of the questions we've answered also on the chat box with Natasha. At this moment, I would like to allow Daniela to share closing remarks regarding this webinar. Thank you.
Thank you. Pardon me. Thank you, Elizabeth. And a very big thank you to our very distinguished panel, Dr. Mary, Adila Hululiwe, Dr. Bartilo. Many, many thanks for your insights. And thank you, Nyawira, for moderating and bringing out the insights so well. This webinar, the topic of this webinar is really reflective of the essence of COA, because a unified approach is what is needed if we are to fight this threat of cancer. So the coalition is a coalition of like-minded stakeholders from NGOs, from private sector, because we know that we cannot fight this alone. Henry Ford once said that coming together is a beginning, keeping together is progress, and working together is success. So this webinar is just one step in keeping together. Let's keep the conversation going, but let's make sure that we remain together to bring success to all our aspirations. So my job here is just to say thank you from Africa Health Business, the Secretariat of COA. On behalf of COA, it's a big thank you. And I want to tell you about a few upcoming events. Actually, one main upcoming event. Please save the date for 26th and 27th of June next year in Lagos. We're going to talk about leveraging innovation to advance universal health coverage in Africa. And we hope to see many of you there. You can go to our website to get details of that event. For more insights on women's health and the work that the coalition has done over the last 2 years, as you know that research and knowledge is one of our pillars. And so we've come up with some publications that can really give you insights on what is happening across the continent in women's health. Go to the COA website, that is www.coa.net, and you can download these reports and feel free to quote from them as you do your advocacy and engagement on women's health. For more inquiries, if you want to contact us, the contacts are on your screen. You can contact the coalition for partnership. If you can show the next slide, IT team. You can reach out to us. You can chat us on the website, on our social media. And please post your thoughts on this webinar and tag us on LinkedIn. Thank you very much. Have a good day.
Thank you, everyone. Good day.
You can also scan the form.
Good day.
Thank you. Bye.